Hi everybody, thank you for allowing us to speak. We are representing adult hospital in the home at Monash. I want to make that clear to start with. We have a paediatric service that provides cancer care as well, but we are adult only. So this is our experience. So for those that don't know, Monash Health sits in the southeast part of Melbourne. We cover about 1.3 million people as our primary catchment, and we have everything from neonatal intensive care through to aged care facilities, so we cover the spectrum of life. We're also associated with Australian Catholic University, Deakin University and Monash University, so we have a lot of input from a lot of different people, which we believe helps us to provide a better standard of care. So we work within the hospital in the home service. We are 138 hospital in the home beds based across 4 of our acute care campuses. And in 2012, we heard about a grant. Every hospital in the home person, if there's any in the room, understand that money for hospital in the home is not really easy to come by. So Anita was the unit manager at the time and was heavily involved in us starting our trek into cancer care, and we decided to do it as a telemedicine project. And the big decision that Monash Health made that has changed how we care for our patients is the decision on workforce training. We trained all of our HIS nurses in cancer care as opposed to setting up a cancer care unit. So our initial aim was to try and find a way to provide care for the patients where they would like it. And please tell me if you can't hear me. We were really lucky. The day chemo unit and the oncology unit were very open to these conversations, and through the whole process have been very involved. And our aim is to give people the care they need where they would like it. How are we going? So our biggest challenges was staff training. We had a very experienced workforce of medical, surgical nurses, a lot of ED and ICU nurses, very few that had had any exposure to cancer care. And our big challenge was getting our staff into the headspace that this is something that they wanted to be involved in. We had staff that eventually came to the party and embarked on this journey with us, but that also then reflected on the patients. So we had patients that were comfortable going to the chemo day units and receiving their care there. A couple would agree and come onto HIS and trial us providing their care, the mechanics of which HIS nurses do all the time. We manage PICC lines all the time, we manage Baxter infusers all the time. There was nothing scary about what we were doing from a nursing point of view, but there was a lot of fear about what we didn't know. And that reflected on the patients, because if they were at all unsure and you had a nurse walking in who was at all unsure, you ended up with a loss of confidence and the patients went running back to CDU. We didn't really blame them, but it was something that we've had to work through from both a quality point of view and a safety point of view. So we're very happy to say 6 years down the track, our program is now really well established and it has had really amazing outcomes for our organisation that's in a huge growth corridor, has more and more patients requiring care for their cancer, and not too much extra building of cancer services in a bed-based setting or in a CDU setting. So with using the hospital in the home department as the release valve, really, to be honest, we've managed to reduce how long people have had to wait for their treatment and hence increase the ability of our organisation to meet the demand for services. From the patient's point of view, we've with our confidence has grown their confidence, and we're really happy to say that most of our patients love that they don't have to go into hospital to receive their chemotherapy. A lot of our treatment protocols, they have their first or their starting of their treatment in the hospital, so they get the specialist cancer nurses that they can ask the curly questions to, and they get the reassurance of that, and then they get the rest of their treatment at home. And then they don't have to drive. They don't have to put their kids in childcare. They don't have to pay an extraordinarily large amount for parking, and I'm sure we're not the only one that charge patients a fortune. They don't have to spend a day out of their life, which may be time limited, in the hospital. They sit at home, they wait for a phone call half an hour beforehand, we turn up, do what we need to do, and they get on with their lives. So, as we have gone along and as we have become more confident, more competent and more engaged, as you can see, our growth in the amount of chemotherapy patients we see per month is going up and up and up. We're hoping it will continue to go up, and we're very lucky that the head of oncology and haematology are engaged with us doing this. So currently we treat 7 different agents, use 7 different agents within our hospital in the home. 4 IV, 3 subcut. Yes, we know the subcut don't really qualify under the VAED guidelines, but we're working really closely with our health information services to make that happen. Sometimes we don't get paid, but it's worth it for the patients, and we're lucky our organisation has supported us in that stance. And we actually have a haematologist and an oncologist as part of our HIS medical workforce, which has given a lot of confidence to the units, and it, for us, is vitally valuable. So, how we've done it with our staff, all of our HIS staff, and there's 70 EFT, have gone through the ADAC modules, the ADAC study day, they have supernumerary time in the day chemo unit to get their hands on, and then they do a yearly update on our spills and skills. So while our staff would not claim to be cancer nurses, they have the skill base to be able to deliver cancer services from a chemotherapy point of view. And in fact, we're extending beyond just chemotherapy with this patient group. So we have moved into the supportive care. So we have some patients we may see for chemotherapy who then get to a point where that's really not what they need, and we actually take them on and we allow them to have quality of life. So people with pleural effusions, we put in a tunnelled intrapleural catheter with the cardiothoracic and the respiratory units, and we manage drainage of their interpleural effusions at home. We go out, we drain them. We've got an amazing relationship with our palliative care team who assist us in other symptom control, so pain and nausea with those patients. And our feedback from families is that's quality of life they have with their family member at home at the end that they wouldn't have got otherwise. So that's really, really well accepted. We have just recently gone into acidic management for people with metastatic, ovarian. We've got a breast cancer at the moment. We've had some pancreatic cancers. Thank you, Claire. And we drain them at home. Again, normally they would have had to have come in to the hospital once a week, twice a week, had 5-7 litres drained off, and then they go home. We go to them, we provide it in their home. It's something that we're still working through, but and we've had some challenges with it, we're not going to lie, but we think it's something that's really important from a quality of life point of view. And we're working with pain, nausea management, symptom control. So it's a bit beyond chemotherapy, but it's related. And how do we want to go with this? We want to do more. Our patients tell us that they like it, the organisation likes it, because we're the release valve when demands get too high. It's cost effective PIS costs about a quarter of a bed day for an inpatient bed, so the organisation likes it. And we'd like to do more, and we think we should. So our quality challenges as we went along were who was going to do it. And I know other organisations have got models where they have chemo nurses to go out and do it. For us, with the size of our catchment, that was not going to be effective, because if you have 1 or 2 people off sick, you've got nobody to provide the care. We made the decision, spend the money, spend the time, have a workforce. It's now a core component of HIS care, and everyone that works under HIS now knows if that's not what you want to do, we understand, go work somewhere else. It's harsh, but it's the stance we've had to take. All the staff now, I think we can quite happily say, enjoy it. It's different to doing normal HIS work, so it's enjoyable. They've all done their training. Am I going? Next one. The big thing that we really had to consider was OC health and safety, and this for us within our organisation has been a huge minefield, and if anybody's got a better answer than we've got, we'd love to hear it, because all of the guidelines are vague. What WorkSafe say is different to what EPA say, which is different to what EverQ say, which is different to, you go to every site, everyone says something differently. Our aim has basically been to keep, our job is to keep our staff safe. We keep our staff safe and well, they'll look after our patients. So we've probably erred on the cautious side, but it does have, providing care in the home, some significant challenges for our staff. You think those days at a 42, 43, you gown up in PPE in someone's house that doesn't have an air conditioner. It's pretty hard yards. So it's something we're still working through with our staff to try and make it better with the priority of being safe. And you have to put money aside when it comes to that. You have to give the staff what they need to allow them to confidently provide the care. Okay, any questions?
Thank you very much. I think you've absolutely raised a storm of questions. And so given the time, what I'll do is just give the audience a flavour of the questions. So if there are people with similar questions, please come and talk to Helen and Anita during the break. But just to give you a sense of some of the stuff that's coming up. How do you triage patients? At what point in their journey do you triage them to have chemo at home? Is it a one nurse, one patient model? How economically viable is that? How do you take account for travelling distances? Would it work in a more regional, rural area? Do you have documented governance models for home-based regional chemo services? How do you get your funding for extended services? And what is your experience of governance arrangements for private chemo providers in the home? And Robin, you might want to get involved. Robin Wilson here also has an experience there. Yep. So I just wanted to put those out there. So if there are people with similar concerns, please come and ask the ladies during the break. But thank you, you've clearly touched on an important part. But is there one question beyond that that somebody has at the moment for Helen or Anita? We're standing between break. I will let people come and talk to you during the break. Okay, thank you very much indeed. Thanks. Thank you.